prototype hyperviscosity syndrome. You may also have circulating prothrombotic particles that are produced. So just go around and say, hey, wake up clotting pathways, and just sets off, just triggers everything. Now, the anti-clotting pathway factors, protein S, antithrombin, their levels are actually decreased. So again, the scales are tipped toward thrombosis. And you may also have a transient positivity of lupus anticoagulants or antiphospholipid antibodies. Now, it's not unusual to see lupus anticoagulants and antiphospholipid antibodies being positive in somebody who has a viral infection, and we don't know the significance of it, other than to know that it may cause your PTT and PT, but predominantly your PTT, to be prolonged in these patients. D-dimer is high because, as we mentioned, the anti-clotting pathway is very active. So your fibrinogen breakdown and fibrin split products are going to be elevated. Now, platelet count usually is normal. It may be slightly increased as it is a pro-inflammatory state, but you traditionally or you typically don't get low platelet counts. When you see low platelet count, you should think of another diagnosis that's contributing. Because COVID doesn't happen in a vacuum. The patient may have other things going on. It may be your treatment that is causing the drop in platelet counts. Rarely, you may also see immune type mediated thrombocytopenia. So ITP may also occur in COVID-19, but this is unusual. Now, there are other hypercoagulable states. So the fact is, the patient often has other things that they're bringing to the table, and we must remember that. Often the patient has comorbidities. So, you're more and more we're discovering COVID positivity in patients who came in for other reasons, motor vehicle accident, gunshot wound. You're a cancer patient, you're here for chemotherapy. So all these other things bring to the table other reasons why your patient might be hypercoagulable. More and more renal patients are turned up because, dialysis units are closed space. And if you're not very strict with protocols, and the patient themselves are not strict with protocols when they leave the unit, it's a prolonged period of contact. And so you can have outbreaks of COVID in that setting. So end-stage renal disease patients quite frequently being selected as COVID patients, or higher preponderance of them among COVID patients. Chronic liver disease as well is a procoagulable state. Obesity, though it's at the bottom here, probably should have moved further up. Obesity is another hypercoagulable state, and even more so in COVID-19. So we know it's a hypercoagulable state. We know there's endothelial injury, and we know there's stasis. So the three factors combine to give you thrombosis. And that has been proven on autopsy studies and also clinical studies. We see them getting PEs. There's overt PE in some patients, but when they do autopsy studies, what they're discovering is microthrombi in the alveoli capillaries, which is likely accounting for the shunting that we see when we see this just refractory hypoxia in these patients. They develop thrombotic microangiopathy, and this is not just in the lung, but also in the glomerular capillaries, leading to this COVID kidney disease. The severe endotheliitis as well is seen in the lung tissue. And as a response to the hypoxia and all the widespread damage that is occurring, there's an attempt at angiogenesis. And these vessels may bleed, so you may see hemorrhage, though hemorrhage is not a predominant feature of COVID-19. Now, with COVID-19, the thromboses, classically we see DVT and we see PE, but you do have arterial thromboses. And these do occur during the illness, and seemingly after recovery, there's still that heightened risk. So just to reiterate these risk factors for thrombosis: obesity, cardiovascular disease, hypertension, diabetes, older age. Looks familiar because that's the list of comorbidities that we're looking for in COVID-19 to determine that you have a higher risk of mortality. An increased D-dimer is associated with an increased risk, but of course, the mechanism by which D-dimer is released, it's from fibrin split products. But having severe illness, being admitted to the ICU, that is correlated with you developing thrombosis. Now, the diagnosis of venous thromboembolism in COVID-19, it's not much different from in a non-COVID-19 patient. D-dimer is not specific for thrombosis, even though it can go very high. It's not unusual to see values as high as 10,000 in a patient with COVID-19, where the cutoff is 500. So it's not unusual to see 10,000 and the patient doesn't have a thrombus. It's just severe COVID-19. Now, the good thing about the D-dimer though is its negative predictive values. So if your D-dimer is normal and you really don't have a high pretest probability, then you can rule out venous thromboembolism. Now, if you have a high D-dimer though, that's not enough to say, okay, that's definitely a PE or a DVT. You still need to prove it. And CT is gonna be the gold standard for pulmonary embolism because VQ, the other test, is not readily available. And secondly, it's going to be difficult to interpret in somebody who has extensive parenchymal disease. Ultrasound is still going to be useful for diagnosis of your DVT, but also arterial. I recently had a patient who was admitted with COVID-19, moderate disease. So we had him at St. Joseph's, actually was fine, discharged, and 3 weeks later developed an acute thrombus to the brachial artery, which ended up with him having amputation. And this is, as far as we can see, his only risk factor was the fact that he had a recent history of COVID-19. So that risk is even persisting when you're outside of that isolation period. So anticoagulant therapy is part of the management of COVID-19, and it is prophylactic therapy that is advocated. So it is indicated for all hospitalized patients, unless you have a contraindication that the patient is bleeding or had a recent bleed like yesterday. So the treatment thereby would be heparin, unfractionated heparin, or low molecular weight heparin. Now, rivaroxaban can be used. It's the only DOAC that actually has evidence for utility in COVID-19. It's the only one that's been studied, but as you know, it's the one that's not available in the public system, so the patient would have to pay for that. And ideally, you really should continue your prophylaxis even after discharge. Now, the period that you continue for is going to be individualized. So if the patient has other risk factors, you may choose to go on for 3 months. It's really, there's no guideline to say how long you should continue. And so it's really up to the practitioner. I know I tend to go personally a month minimum, but there are those who develop chronic lung disease. Somebody who develops chronic lung disease from COVID, and I'm going to continue that for at least 3 months. Now, full dose anticoagulation is indicated if the patient actually has a confirmed thrombus, all right? Or if this is atrial fibrillation or some other non-COVID-19 indication, right? Now, I put suspected and presumed PE. No, because it's important to note. So while, the management is with prophylactic therapy, sometimes you don't know if a patient has a PE and you can't afford to not treat the PE. And you have to weigh risk versus benefits. So if you know that the patient, has a high D-dimer, they're really short of breath, they're really hypoxic, there's a strong possibility PE is on board, you don't have access to CT scan, you're going to anticoagulate until you prove that it is not a PE. Then you can withdraw full anticoagulation and de-escalate to prophylaxis. Because if in fact the patient really has a PE and you're there, well, the guidelines say not for D-dimer, you have to have proven PE. Then you can cause further harm and that patient may die. So in everything that we do, we have to weigh risk versus benefits. So heparin, is utilized heavily in our COVID-19 patients. It is usually the choice for prophylaxis, whether it's unfractionated heparin or low molecular weight heparin. But it's not just about its anticoagulant properties. It actually does have activity against the virus itself. Whether or not this is actually affecting the disease in vivo, we don't know, but in vitro, we know that it acts the spike protein, which is what binds to the ACE2 receptor and allows the virus to enter the body. Heparan sulfate, which is a naturally occurring heparin, right, actually interacts with that spike protein, and it's actually a co-receptor. So similar to how in HIV, co-receptors, similar mechanism with SARS-CoV-2. So heparin may have a role there. Now, it also has anti-inflammatory properties that we know. And the mechanism that's been proposed for that is its ability to dampen the activity of pro-inflammatory transcription factor, nuclear factor, kappa beta. Now, NF-kappa beta actually reduces in turn several cytokines, but of note, you see interleukin-6 here, which you know has very high activity in COVID-19 and is one of the targets for therapy for COVID-19. Tocilizumab, case in point, targets IL-6. Now, all of this is based on physiological and laboratory studies. We don't know from randomized clinical trials if really heparin is superior to the others because of this activity. That data needs to be teased out. But heparin is widely available. It's the most available of the anticoagulants. And there may be a potential benefit, so go ahead and use it because that is what most persons use anyway, and you may have these additional benefits. Now, therapeutic anticoagulation, most guidelines, ours included, would have said that once the D-dimer is above a certain threshold, and that threshold was 1,000, then we would go ahead and do full anticoagulation. And this is because D-dimer, again, is associated, it's a poor prognostic factor. The persons with the high D-dimer were the ones who were likely to die. So these are the critically ill patients. So it was an escalation in their care. So with D-dimer-based anticoagulation, REMAP-CAP was a trial published in the New England Journal of Medicine, actually in August, I believe, to full anticoagulation versus just doing prophylaxis. And what they found was that those who received full anticoagulation had less thrombosis. That makes sense. They also had more bleeding. That also makes sense, though the bleeding rate really was not that high. But what they did know was there was no difference in survival, which is really why you want to treat patients so that they survive. All right. Now, another trial, which was the Inspiration trial using enoxaparin, looked also at critical patients.
You hear was tell me about my old phone?
Someone needs to mute.
My old phone in a meeting the same way.
So with the Inspiration trial with the ICU patients, what they noted was there was actually no improvement in outcome when they used therapeutic versus prophylactic anticoagulation, and the composite they looked at was the use of ECMO, whether a patient develops thrombosis, so documented thrombosis, or mortality. So it did not favor or did not show that there was a benefit for full anticoagulation. So what these trials are saying is not that we don't need heparin, that we should not use heparin in these patients, but they're suggesting that you're not gaining additional benefit from going to full dose anticoagulation just because it's COVID and the D-dimer is high. What it should be, what they're suggesting is that your use of full anticoagulation should be based on whether or not the patient actually has proven thrombosis. And I put it to you in our setting, whether or not there's a high suspicion for thrombosis because of the limitations we have in getting the diagnosis, transporting the COVID patient to another facility to get the CT scan done. CT is not working at KPH, CT is not working at UE. So we have all of those issues to think about and have to decide what is the best thing for my patient, since I have delays in establishing whether or not this patient has thrombosis. So I personally would lean towards a patient with a really high D-dimer who I am suspicious that there might be a thrombus on board. I'm going to go ahead and get my scan as soon as possible. And when I get my scan and my scan says no clot there, then I downgrade you back to prophylactic therapy. For the moderately ill, the same trial in the New England Journal of Medicine, the REMAP trial, showed there was no statistically significant difference for thrombosis or survival, whether you use full anticoagulation or used prophylactic dosing. Action trial also was another D-dimer-based module. They looked at enoxaparin, and they also looked at rivaroxaban. So again, I'm saying rivaroxaban is a DOAC that is utilized where you're not using parental therapy. And they looked at a composite of survival, length of stay, direction of oxygen, and again, no statistically significant difference. And I want you to also appreciate that though they're not seeing a statistically significant difference in terms of survival, they really aren't appreciating high rates of harm to the patients because they receive full dose anticoagulation. Yes, bleeding was more, but in some of the trials, it wasn't statistically significant, or where there was bleeding, it did not impact survival, or it was not severe bleeding. So when you have documented thrombosis in COVID-19, usually we go to unfractionated heparin or low molecular weight heparin, but note the risk. There's a risk of heparin-induced thrombocytopenia with thrombosis, all right? And so if a patient has had a history of that, of course, you can't use a heparin-based therapy. You have a lower bleeding risk if you use low molecular weight heparin versus unfractionated heparin, but unfractionated heparin is a little bit more predictable in its reversal. Protamine sulfate is readily available, as you know. If you do prefer parenteral therapy for initial anticoagulation, if the patient has a high risk thrombus, so this is saddle embolus, bilateral PE, islet DVTs, cerebral, and we're more likely to use these types of parenteral therapy. Now, if it's end-stage renal disease as well, you'd rather unfractionated heparin because you really shouldn't use low molecular weight heparin in very low GFRs. The risk of bleeding and complications is much higher, and the excretion of low molecular weight is more low molecular weight heparin is more renally skewed than it is with unfractionated heparin. Warfarin still exists. You know, I can't tell when last I used warfarin, but warfarin also has use, particularly if this is a patient who has end-stage renal disease. Again, they're probably stable for home and you're going to have to continue anticoagulation and they can't afford the DOACs. Then there's a role for warfarin. Remember that DOACs are also not utilized in persons with mechanical valves or in antiphospholipid antibody syndrome and lupus anticoagulants. So there's still a role for warfarin. But again, the issue is with monitoring, and especially now, you don't really want to crowd your health centers and hospital clinics with INR monitoring. For the DOACs, you know, they have a lower bleeding risk. The one that we have available to us is direct thrombin inhibitor dabigatran. We don't really have any trials on its use in COVID, but we use it because that's what we have. Among the factor 10A inhibitors, 3 are available locally. Fondaparin, as you know, is parenteral. Apixaban can be used in your renal failure patients. So I would actually lean towards using it in a renal patient than warfarin, again, because no need to monitor. You can, but most persons with VTE, you can use a factor 10A inhibitor. Rivaroxaban also has, apart from studies showing its use in COVID-19, also has use in non-COVID rare issues like malignancy, and in somebody who has to be on triple therapy. So somebody who has peripheral vascular disease, a history of coronary artery disease, and now has to be on aspirin and clopidogrel. I know you're going to have to add an anticoagulant, where the bleeding risk is going to be astronomical. There's a role for using rivaroxaban in those patients. All right, so each has their own little nuance. We know that apixaban has the lowest bleeding risk of the 3. All right, and these drugs may also be used if the patient has heparin-induced thrombocytopenia with thrombosis. All right, remember that they're not used in pregnancy. So your pregnant patient, you're going to end up using low molecular weight heparin. And that is the end of my presentation on anticoagulation and COVID-19. And any questions or at this time?
Thank you, Dr. Nicholson Spence. I want to say I am not the person to give that official thank you, but your presentation I know has been is being well absorbed, but we will have the questions after the next presentation. I do hope you're able to stay with us a bit so that the questions which when fed, you will be able to answer. Is that okay?
I will try.
Great. Thank you again for your presentation. Very, very stimulating. I see somebody said, Latoya Blaishaw, and I know she's from Black River. She said, lovely presentation. And others I know will be coming in, but we'll just take the questions after the second presentation. Thank you. Good afternoon again, all 230 participants, 31. I know people are still cooling off in the waiting room before they get inside. Our next presentation is something that we've all been curious about, the COVID-19 and its impact on premature births. And the presenter to do this is Dr. Batchelor, and she will be introduced by Dr. Peter Gay Clemens.
Okay, I humbly introduce Dr. Trudy Ann Batchelor Price, who is a consultant, OBGYN, and maternal fetal medicine specialist at the Spanish Town Hospital. She has a great passion for the ever-evolving obstetric medicine and is a devoted full-time wife and mother of two. She will now speak to us on the COVID-19 pandemic, being amongst the causes of premature births here in Jamaica. Please let us welcome Dr. Batchelor Price to the floor. Thank you.
Good afternoon, everyone. I have been given the privilege of speaking uniquely about two beings today. So we're speaking about our obstetric patients and our in utero passenger, soon to be our neonate. So today we're gonna speak about preterm births and COVID-19, or the reverse, COVID-19 and preterm births. Of the Delta variant, we're seeing a lot more complications in our obstetric patients and the resultant neonate. So what is the significance of COVID-19 and preterm birth? Now, preterm birth is one of the strongest determinants of child health and development, and is therefore an important outcome that we must consider in the context of COVID-19 diagnosis. Having said so, there are dramatic inequities. Of course, we see that globally in the burden of COVID-19 infection and death, with a predilection for particular ethnicity and socioeconomic groups. This also results in healthcare disparities. Again, we're speaking about the emergence of the Delta variant and what we're seeing as the complications associated with our obstetric population who have severe disease. Now, we're gonna speak just a little on what preterm birth is. So it refers to birth that occurs from 20 weeks. And of course, this varies geographically. We will use 24 to 36 plus 6 weeks gestation. 70 to 80% of preterm births are spontaneous. Of this 70 to 80%, 40 to 50% result from preterm labor. 20 to 30% result from preterm pre-labor rupture of membranes, and 20 to 30% from cervical insufficiency. Now, 20 to 30% of preterm births are initiated by the healthcare provider for maternal or fetal issues that jeopardize the health of either or both. And this is where it becomes important in COVID-19 and our obstetric patients, because as the presentation goes on, you'll see most of our cases of preterm births are actually medically induced. Just some more definition of preterm birth. So we have our moderate preterm births or very preterm births, extreme preterm births. We also go birth weight, which is less than 2,500 grams, or very low birth weights, less than 1,500 grams, and or extremely low birth weight, less than 1,000 grams. Preterm birth is generally, preterm birth is relatively common. And I want you to remember these figures, that it occurs in 5 to 18% of births worldwide. And we will see how significantly this incidence is increased in our COVID-19 population of obstetric patients. Some risk factors I'm going to mention, and I will highlight a few shortly. A history of prior preterm births, especially in the case of multiple preterm births or preterm birth at an early gestational age, increases the risk of a subsequent preterm birth. Prior cervical surgery, for example, or patients with our abnormal pap smears who may have large loop excisions of the transformation zones, or cases of multiple dilatation and curetages. Uterine anomalies, uterine fibroids are very common in our ethnic population. Then maternal demographics, extremes of age, patients less than 17 or greater than 35 years, or non-Hispanic, educational level, single marital status, lower socioeconomic status, which may really speak to their ability to seek health care, short inter-pregnancy intervals, and other social factors, poor access to medical care, physical abuse, acculturation as well. Others, the nutritional status or physical activity of a patient, BMIs less than 18, or a pregnancy rates less than 50 kilograms, not so much obesity here. Poor nutritional status, long working hours, greater than 80 hours a week, hard physical labor, multiple pregnancy, the maternal and pregnancy characteristics, multiple pregnancy, fetal abnormalities, vaginal bleeding, and our list continues here. Now, I'm going to speak about some of the topical risk factors, which may actually mirror some of the risk factors for COVID-19 in the obstetric patient. Now, as far as race and ethnic groups apply, the incidence of preterm births will vary among the ethnic groups. In 2018, in a United States study, where they looked at the non-Hispanics, the Hispanics, non-Hispanic white, non-Hispanic blacks, they found that these rates were 14.1, 9.7, and 9.1 respectively. There is a higher rate also of low birth weight infants in these minority populations, with 11.5, 9.4, and 5.4% in Asians, Blacks, and white mothers respectively. The underlying cause for this may not so much, but they have entertained biological or environmental factors. But I think most persons believe that there are environmental factors relating to their access to care. Now, age. Older mothers have a higher prevalence of pre-existing chronic disease and obesity. They also have a high rate of unintended pregnancies. As a result of this, you may find that an obstetrician may have to intervene because of these chronic illnesses. These older mothers also may, because their pregnancies are unintended, they may also have not sought antenatal care. This just highlights an obstetric patient, a 66-year-old, who conceived twins. This would have been back in 2005. Of course, this was assisted reproduction. Stress. This occurs, is thought to be a contributor to preterm labor and is also a contributor, we think, to some of the outcomes in our COVID-19 patients. Most women report experiencing at least one stressful life event in a year before giving birth. There has been the association between post-traumatic stress disorder and preterm birth. The evidence that maternal and fetal stress activates cells in the placenta and the decidua and fetal membranes and produce corticotrophin releasing hormones. And this same hormone enhances local prostaglandin production, which initiates contractions. Of course, it is difficult to define and to measure maternal stress. Weight. The obese patients are at an increased risk of, I mentioned earlier, the iatrogenic preterm birth, and this usually results as us intervening in the case of medical complications. It also increases the risk of preterm pre-labor rupture of membranes and may also increase the risk of spontaneous preterm birth without ruptured membranes. It is thought that this spontaneous preterm birth associated with obesity is mediated by an inflammatory state. But again, the data or the jury is out on whether this is so or not. Coitus, a lockdown activity. The effect of coitus on preterm labor is uncertain. It has been noted that there is a decreased risk of preterm birth reported in patients who have intercourse later in pregnancy, also or orgasmic intercourse. On the contrary, there is an increased risk of preterm birth linked to orgasmic coitus in the preterm period. And this is as a result of prostaglandin E found in semen and also breast stimulation, which hastens the onset of labor. Diet. Women with adequate nutrition and normal body mass index appear to have a better pregnancy outcome than women with extremes of weight or diet. And this suggests that there may be some nutritional role in preventing preterm birth. There is also some evidence that supports the hypothesis that maternal undernutrition in pregnancy results in preterm birth. In animal studies, moderate maternal undernutrition around the time of conception resulted in accelerated maturation of fetal hypothalamic pituitary adrenal axis, and as so would have caused precocious fetal cortisol surge, and again, the risk of preterm birth. With all these risk factors, whatever the cause, the terminal cascade of events results in labor. Preterm labor therefore occurs when there is local uterine factors which prematurely stimulate this cascade, or there is inhibition of these suppressive factors that would have ordinarily maintained uterine quiescence. Ideally, we should aim to identify the modifiable and non-modifiable risk factors of preterm birth prior to conception or early in pregnancy and intervene to prevent this complication. Some of the reasons why we may intervene or there may be initiated preterm labor are these below complications of pregnancy: preeclampsia, placental abruption, placenta previa, intrauterine growth restriction, and maternal or respiratory compromise. I want you to make note of these two factors, preeclampsia and maternal respiratory compromise, which we will speak about shortly as well. As it pertains to COVID-19 or early term birth is limited. Initial studies that were performed in Wuhan, China, where there was predominantly a homogeneous population. So as it relates to an ethnically diverse population, we do need more studies, but there have been a few which I will discuss as well. I will proceed to give you a little tour through our obstetric and neonatal unit. So this is our entrance to our neonatal unit. And here it is. It says my connection is unstable. Am I being heard still?
Yes, Dr. Bachelor, we're hearing you.
Yes, we're hearing.
Now, as it pertains again to COVID-19, pregnant and non-pregnant patients of racial and ethnic minority have a higher rate of COVID-19 associated hospitalization and severe in-hospital outcome. There has been great concern about the impact on pregnancy outcome in these patients because of the high maternal morbidity and mortality, particularly as we try to overcome this Delta surge and neonatal morbidity and mortality. There's also the concept or the thought of vertical transmission, whether there is truly congenital infection, the risk of postpartum infection, the safety of antiviral drug therapy and convalescent plasma, and the safety of vaccines in the obstetric group. What are some of the considerations then in these obstetric patients? These obstetric patients should be counseled about, that is our obstetric patients with COVID-19, should be counseled about the increased risk of severe disease, which is real, receive recommendations on how to protect themselves and their families, and if hospitalization is indicated, care should be provided by a facility that can conduct both maternal and fetal monitoring. This is the outside of our maternal high dependency unit, which is in full swing with our obstetric COVID-19 population. Other importance. In general, therapeutic management of the pregnant patient should be the same as the non-pregnant patient in general. The COVID-19 treatment guidelines, which was modified on July 8, 2021 by the National Institute of Health, recommends against withholding SARS-CoV-2 vaccination from pregnant and lactating individuals. And by strong expert opinion, also recommends against withholding any form of treatment for these patients. And this is the reason why we have a lot of medically induced preterm births. Now, pregnant women are more likely to experience complications physiologically of respiratory viral infections because of the following. There are physiological changes in the elevation of the diaphragm, which decreases lung compliance. The hormone of the respiratory tract leaves it more increased in the oxygen consumption. There is also pregnancy-associated immunological changes with a shift in T helper 1 cells to T helper 2 dominant immunity. This increases the vulnerability to intracellular pathogens such as viruses. And this is likely to be associated, like I said, with or has been associated with higher morbidity and mortality rates in H1N1, as we have seen SARS-CoV-2 and MERS-CoV-2, and by extrapolation, we believe the same for SARS-CoV-2. Having said so, the shifting T-cell immunity may also confer some protective benefit against severe inflammatory response, because these T2 helper cells are associated with more anti-inflammatory mediators. In a patient who has COVID-19, the pregnancy progression tends to be mostly mild to moderate disease. Most obstetric patients are managed at home. The large majority of patients that have been studied, these cases are reported of patients in their second and third trimester, and most of these patients have had a favorable outcome. In a study by the CDC of about 23,000 pregnant patients versus 386,000 non-pregnant patients who had laboratory confirmed SARS-CoV-2 infection, these are some of the symptoms that presented, which are similar to the non-pregnant patients. And we're all aware of these symptoms. The most common being cough, followed by headache, muscle aches, fever, sore throat, loss of taste or smell. And of course, the others such as diarrhea, nausea, vomiting, fatigue, rhinorrhea. Now, seeing the obstetric population as we do that with normal symptoms of pregnancy. So it is very difficult to distinguish what is physiological, what is pathological. So our index of suspicion is very high for these patients. The body of evidence as pregnancy progresses in these COVID patients suggests, like I said, a mild to moderate clinical course. More than 90% of these infected obstetric patients recover without undergoing hospitalization. However, in these same obstetric patients, there can be rapid clinical deterioration. And this is more common in patients who have severe disease, or it increases their risk rather of severe disease and death compared to that of a symptomatic non-pregnant female of similar reproductive age. These factors that may increase their rapid deterioration are older age, more than 35, obesity, and these pre-existing clinical medical comorbidities such as hypertension, diabetes, or a combination of both. And again, you will see the comparison between our risk factors for preterm labor now presenting itself as risk factors for severe COVID. How do we classify? Well, the classification of disease severity in the obstetric population is similar to that in the non-obstetric population. So we have our asymptomatics or mild, moderate, but let's focus on severe disease illness. Where our oxygen saturation is less than 94% on room air at sea level, where there are lung infiltrates more than 50%, or where our PaO2 and FiO2 is less than 300. And then of course, critical illness where there's respiratory failure, septic shock, and or multiple organ failure. This seems to most times be a very terminal event. In this same study created by the CDC of our obstetric population, the pregnant patients, when compared to these non-pregnant patients, the ratio of ICU admissions were 10.5 to 3.9. Those receiving invasive ventilation, 2.9 versus 1.1. And these are significant. Those receiving ECMO, 0.7 versus 0.3, and death, 1.5 versus 1.2. A similar prospective cohort study comparing fewer patients gave ratios. Death was fairly similar, 1.5. Pneumonia, 9.9 versus 6.5. ICU admissions, 13 versus 6.9. So there is no doubt that our obstetric population, when there is a severe illness, do suffer more than the non-pregnant population. In an observational cohort study of all pregnant patients at 33 hospitals, the data when evaluated for patients who again had laboratory confirmed SARS-CoV suggested also that the adverse perinatal outcome was more common in patients with severe or critical disease than in asymptomatic patients. The incidence of cesarean section in this group was 59.6 versus 34%. The incidence of hypertensive disorders of pregnancy was 40.5 versus 18.8%. And here we are, preterm birth, 41.8 versus 11.9, an almost fourfold increase. The perinatal outcome for those with mild to moderate illnesses seem to have been the same as those observed among asymptomatic patients. So it is obvious now that we have to target our obstetric patients, to have them vigilantly managed when they present with severe illness. As I mentioned already, preterm birth is one of the strongest determinants of child health. Et al. It showed that COVID-19 diagnosis increased preterm birth by 59%. Most of them, they were primarily medically indicated rather than spontaneous preterm births. Of course, again, we lack evidence from large population studies that examine ethnically and race diverse groups and socioeconomic status. Even the availability of health insurance is a factor. A lot of the studies that we have looked at or that has been published did not distinguish between spontaneous or iatrogenic preterm birth. We will use data from the live births between July 2020 and January 2021, which determined the association between COVID-19 diagnosis and preterm birth. And to date is one of the largest studies that actually studied the different ethnic groups and race, also socioeconomic status and the availability of health insurance. It showed that COVID-19 diagnosis in pregnancy was associated with a 40% risk of preterm, a 60% increased risk of very preterm, and a 10% risk of early term birth. Of course, our 60% risk of very preterm patient and neonates will suffer more challenges than our other preterm births. There have been purported causes for spontaneous preterm births. The effect of fever and hypoxemia, which is thought to probably stimulate spontaneous preterm birth. The stress, like I mentioned, of the pandemic, and I already went into our lockdown coital activities, which may increase the risk of spontaneous preterm birth. Of course, this would have been in our mild to moderate illnesses. Some of the reasons we may decide to interrupt or to intervene in these obstetric patients are to deliver the patient to begin antiviral therapy, to relieve respiratory compromise, particularly as the patient passes 24, 25 weeks. In the case of fetal distress, which seems to be very common in these patients with COVID-19, and this is thought to be as a result of the microangiopathy that occurs in the placenta, the presence of preeclampsia and HELLP syndrome, and when the patient has acute maternal respiratory decompensation. this is the study I had highlighted earlier, which speaks about the different ethnic groups. We have our whites, or blacks, or Asian. And in these groups, that the majority of them are indicated preterm birth rather than spontaneous preterm birth. Of course, we also have a third group where their preterm birth was not established as either. This speaks now to the different types of preterm birth, or very preterm birth less than 32 weeks, or preterm less than 37, or early term 37 to 39. Let's focus on our very preterm and our preterms under 37 weeks. So you will find that in our Black population, and particularly our Asian population, that the risk of preterm birth less than 32 and less than 37 were higher than other populations. As it pertains to preeclampsia, which is married most times with our intervention for COVID-19 and the incidence of preterm birth, we have found so far that in SARS-CoV-2, there has been a 62% higher odds of developing hypertensive disorders of pregnancy, particularly preeclampsia and HELLP syndrome, and eclampsia in patients who at that time were both asymptomatic and may have also been symptomatic. As it relates to the other factors associated with the significance of SARS-CoV-2 in pregnancy, we have to speak now about the neonatal aspect and breastfeeding. Now, the majority of studies have not demonstrated the presence of SARS-CoV-2 in breast milk. Therefore, breastfeeding is not contraindicated. We encourage bonding with these SARS-CoV-2 positive mothers. Of course, we encourage practicing good hygiene, proper face coverings, and breast and pump hygiene. As far as the therapeutic agents that are used in treating obstetric patients, there has been no decision whether breastfeeding should be encouraged while receiving them. And of course, the decision has to be made between the patient and the clinical team. And of course, it is always a case of a balance in benefit versus risks. So where do we go now with the emergence of the highly contagious variants? We must address prevention of COVID-19. According to the CDC, less than a quarter of our pregnant population have been vaccinated. And it is difficult to convince our obstetric population that vaccines are safe when you have your non-obstetric populations who still deem the vaccination as being something in study. Now, as far as the vaccines available, they do not contain viruses that replicate. They do not cause disease. They may have non-specific side effects, as with most other vaccines. Based on how the mRNA viral vector and protein subunit vaccines work, it is unlikely to pose a risk to pregnant persons, the fetus, or breastfeeding newborns. The vaccines do have your standard adjuvants, but generally we do avoid vaccines which have novel adjuvants. Data from animal studies, vaccinated pregnant persons, and a small prospective cohort of studies have shown no harmful effects. They have demonstrated maternal immune response, which is beneficial to the neonate in the transfer of maternal antibodies across the placenta and into breast milk, and in so passive immunity. The CDC had a very safe vaccine pregnancy registry, which only studied 800 their pregnancy. There was no option when they compared pregnancy loss in terms of spontaneous abortions or stillbirth or preterm birth, congenital anomalies, infants who were small for gestational age, or neonatal death. So, I mean, I can only say that the recommendation, therefore, is that all pregnant patients should receive their COVID-19 vaccine. But especially now, we should focus on these patients who are at higher risk, because these risks are also put them at a higher risk for preterm births. This is just a little trip into our neonatal unit. And here we have our tiny superstars, all our preterm babies who have graduated and have since gone home. And this is where my presentation ends.
Thank you, Dr. Batchelor. Thank you, Dr. Batchelor. Very mighty, tiny and mighty presentation. The babies have taken us over into our question and answer section, but we'll ask Dr. Peter A. Clemens to just answer a few of the questions that were placed in the chat. While for both the two first presentations, for Dr. Nicholson Spence and Dr. Batchelor. Those three, right.
You want to do that? Just do that. Why should put that?
I'm out of the meeting. Oh, okay, I'm back.
So this first question is directed to Dr. Nicholson Spence. In of these patients particularly, and how important is this role? And do you think that an increase in the PT, do you think that, I think that there's an increase in the PT patient ratio?
Okay, the role for the physiotherapist is not clearly defined in the management of
Dr.
COVID-19.
Spence?
Are you hearing me?
Yes. I think it was the first one.
You're hearing me?
Yes, sir.
Okay, I'm saying the role of the physiotherapist is not clearly defined in the management of COVID-19. What you find is disease is not one with a lot of secretions and atelectasis like you would in other forms of pneumonia, where the role of physiotherapy for opening up the airways and tracheobronchial is more defined. The pathology is more with the microthromboses and widespread inflammation causing hypoxia. That being said, though, the role is more for perhaps mobilizing the patient more, passive physiotherapy, limb physiotherapy, that can be helpful. An increase in the PT to patient ratio, that it depends on what the existing ratio is. Because the role for COVID-19, it's not that profound in terms of you seeing a clear association between this particular therapy that is provided by the physiotherapist and an outcome event, to make it clear. So the role of physiotherapy is not that well defined. So I don't personally think that there's a need for an increase in the ratio, not COVID-19 at least, but certainly for many other illnesses in which they're underutilized.
Thank you, Dr. Spence. I do hope that that answers the question and it's clear. The next question is directed to Dr. Batchelor. Dr. Batchelor, is the low incidence of COVID in T1 due to underdiagnosis, since these patients may not be obviously pregnant? 1, and part 2, if so, would you recommend routine pregnancy tests in female COVID patients of childbearing age?
So the question is whether we're having underreporting of COVID-19 infection in the first trimester. That's part 1. And the second part is whether we should be testing all. All right, so most
Hi, Dr. Bash.
Dr. Batchelor, not hearing. I wonder if she fell off. Okay, in the interest of time, we're going to move into the next presentation. I don't want to, and we will continue the question and answers after we've completed the next 2 presentations. I don't want to preempt anything, but of course we know that with all that is going on physically, certainly it affects us mentally. And today when you ask someone how they're doing and you don't hear on top of the world, of course, if you hear that I am here, then of course you know that they're on top of the world, because you're in a very good place today to be just here. You're in an excellent position. So at this moment, we will have a presentation from Dr. Colleen Gooden, psychiatric perspective, and the introduction will be done by Dr. Clemens.
Dr. Gooden is a consultant psychiatrist for St. Catherine Community Health Services. She has worked for the past 20 years in the parish as a pioneer in the development of the community service. Currently, she supervises the psychiatric services in the parish of St. Catherine, which includes inpatient and outpatient care for adults and children, emergency and home-based care, group therapy, and mental health promotion. Dr. Gooden has a particular interest in community and hospital liaison psychiatry. She has a small private practice in Kingston and is also a board member of Family Life Ministry. She is married with 2 children, and in her downtime, she enjoys walking and reading. Today, she will speak to us on a psychiatric perspective of the COVID-19 pandemic. Please welcome Dr. Colleen Gooden.
Good afternoon, and thank you for that kind introduction. We're going to start. So thanks to the organizers for inviting me to present on a psychiatric perspective of COVID-19. And as other presenters have said, it's really an evolving situation as more and more evidence comes forth. So this is just an overview of what has been found so far, studies that have been done from previous outbreaks of coronavirus compared to what's been happening now. Studies coming out of China especially have been
Put my phone in there.
Sorry, somebody's not muted. Ms. McFarlane. Okay. Looking a little bit at just a short introduction to the topic and look at some of the common psychiatric presentations of COVID-19. There are going to be implications for pre-existing conditions, so people who already have psychiatric disorders. And there are also some new conditions that we have to be aware of and on the lookout for. I want to talk a little bit about the etiology or the proposed an overview of management. And of course, because I'm talking to healthcare workers, I will leave you out to just talk a little bit about COVID-19 and healthcare workers in particular. So just by way of introduction, we know that pandemics by their very nature cause millions of people to die worldwide. And it's unfortunate, but I keep remembering and reminding people that we're still in it. So we've not seen the end effect in terms of the deaths and the suffering that's going to be caused by this pandemic. It continues. And we know that our current pandemic has affected not only physical health, but mental and emotional health of our patients. And I'm sure many of us have noticed some changes in ourselves. Mental health problems, because it's a pandemic, it affects people both directly and indirectly. So no matter if you never get COVID, you are vulnerable to being affected by the mental health consequences of dealing with that pandemic. We also have to remember that the vulnerable populations, so the people that we keep targeting for vaccination and to be extra careful, the middle-aged, the elderly, those with pre-existing medical conditions. they have had to come face to face with fear of their own death and a lot of existential issues. It's a very real thing right now. As healthcare workers, the frontline workers, we're exposed to and we're dealing with our own fears of the illness, getting sick, or in our families getting ill. And I put etc., etc., etc. Because we know there are other issues that affect our mental health at this time. So I just wanted to put this up as a list in terms of some of the neurological consequences. And not going to go too much. There are neurological presentations of COVID-19. There are neuropathies, myopathies. We heard about coagulopathies, so we know that anything can come out of that. You can have strokes. Okay, lots of smell, in some instances, direct invasion of cortical neurons. And we know that there's encephalitis, encephalopathy has been reported and the news growing. So when we talk about etiology, we like to talk about biopsychosocial culture in psychiatry. And I'm going to start first of all with biological. So coronaviruses are traditionally considered to be pulmonary diseases and sometimes with GI symptoms, right? We know that we tell patients that, or we're seeing patients who present with GI symptoms as well. However, many patients with COVID have developed neuropsychiatric symptoms. And before, based on studies of previous coronavirus outbreaks, we know that there are several ways in which the neuropsychiatric symptoms may come about. And there are both proposed mechanisms of psychiatric symptoms. First one is that an altered mental state may be precipitated by such as abnormalities which we may see in patients who treat the symptoms of coronavirus, but those same medications may cause psychiatric symptoms. So steroids, high dose steroids we know can cause psychiatric symptoms, and so this is something to bear in mind. If patients are developing acute renal failure, hepatic failure, this hyperinflammatory state to delirium, which is a psychiatric prescription. So this is one of the factors in terms of things that can be medicines. Another hypothesis is that there is it is thought that the inflammatory response can actually affect the blood-brain barrier, and the immune cells actually get inside and start to damage CNS tissue. There have been reports of encephalitis, limbic encephalitis, and of course, if it's limbic encephalitis, it's going to affect things like behavior and mood and that kind of thing. So that is something to be aware of, as well as brainstem involvement, all as a result of the blood-brain barrier dysfunction. We spoke about coagulopathy, and that is something that we need to be aware of. If you have anything that affects the brain, of course, affect behavior and present with psychiatric symptoms. So thrombotic events, strokes, important to know that stroke is the most common neurological finding on imaging of hospitalized patients for COVID. Stroke can even be a presenting symptom by itself, so that is something to be aware of. Although more And we know in psychiatry that stroke itself is a risk factor for depression. So it would be one problem on top of another problem. People have stroke. Another through direct viral invasion of the nervous system, which the literature says is actually rare, but virus can sometimes be seen in this case. I found it interesting to know invasion of the brain. However, it is more likely that it is feelers as a all right. So those are some of the biological issues that can, physiological reasons rather, that patients can present with psychiatric symptoms. However, as we are well aware, there can be psychological stresses too. So there's fear of exposure, especially in us as healthcare workers. Some people develop obsessive and compulsive sort of behaviors with their PPE. I mean, some obsession is good because you want to be very careful, but people may become obsessed to the point of, did I take off my mask at the right time? Did I touch anything with my gloves that I shouldn't have touched? Is everything where it should have been, or did I inadvertently expose myself? So that is something that is a real fear that some people have. Of course, we all have this fear of infection and illness, of ourselves or our loved ones dying. There's stress from isolation. This is a real thing, and people have developed claustrophobia, or people who may have had claustrophobia before, and this has worsened. There can also be stress of inadequate physical distancing. So you may be in a situation where you're not able to have adequate physical distancing. So you may be in a home, a nursing home, you might be in working in an environment where physical distancing is not very easy, and so there's a worry as to your exposure. People have had to deal with real or potential loss of their income, right? Real or potential loss of their job, inability to get the necessities of life because they're not able to afford it, worsening economic problems. People have had to deal with the stress of balancing work and home life. For example, those who may be working from home with their children at school online, or having to balance other things while they're at home trying to work. So this is a source of stress as well. We also have social cultural stressors, overcrowding in some distances, having to go to a facility or to some business to do some office to do business, and finding that there are 100 people bunched up outside and you have to join that line. Social distancing, as I mentioned before, that can be a stress because we're not used to staying away from people. We're not used to having to stand apart, not able to hug, not able to kiss, and that kind of thing. There's stigma in the community. And this is a real thing that we need to be aware of, especially if you're discharging patients. Ask them how they want to cope. I have seen at least one patient who developed PTSD when she went home because people in the community were ostracizing her and her family as if they still had COVID. They knew she was admitted for COVID, and they really made her feel quite unwell from there. We have also, unfortunately, developed this lack of trust in establishment, right? In established organizations. So people don't trust doctors, they don't trust the news, they don't trust the government, right? We've had demonstrations, even here in Jamaica, against vaccines and rights, equaling this right to refuse a vaccine to a basic human right, which it really isn't. Right? People have had to take in a steady diet of fears and rumors and fake news. So this can be a very stressful thing for people to deal with. There's also been, you must be aware, limited access to health care because, of course, our systems are overwhelmed, and a lot of people just have not come to seek health care, even mental health care, because they're afraid. So people have missed their appointments, and people say, well, I'm just not going to go to the doctor because I don't want to expose myself. As I mentioned before, there are existential issues as well, right? People have, well, maybe a lot of people, when they get ill, they start to think, well, why is this happening to me? Or why is this happening to my family member? Is this the end? Do I need to, look at my will and make sure everything is in place? Because yes, it's so unpredictable that no one knows what to expect. And you hear a lot of horror stories as to what happens. So these are some of the psychosocial and cultural issues that people have to face and which can predispose people to developing psychiatric problems. It's important to know that persons who have pre-existing problems, these problems can worsen. So alcohol and other substance abuse problems may worsen at the time. I don't know if you all remember when the pandemic started, in an increase in sales of alcoholic beverages, right? And these people were drinking at home because they were isolated. So we need to be aware of substance abuse. I need to ask people, are you drinking more than usual? Are you smoking more than usual? The best domestic abuse and child abuse has been confirmed that has been on the rise since people are stuck together. Children don't have the safety of being able to leave home and go to school. They don't have that safety net. People in domestic relationships, they are more likely to be abused because they are stuck together and not able to go to work. So this is something that is real as well. People have to deal with grief, having lost their loved ones, having lost their job. Any kind of loss can lead to grief. Depression, people who suffer from depression and anxiety disorders, especially if you've had a phobia before, or if you've had panic attacks before, this can worsen. Right? And as I said, there can be a decrease in access to healthcare because curfews and lockdowns mean that sometimes people can't get to the pharmacy to purchase their medication or even to see the doctor. I just wanted to mention very briefly about delirium because it is a common presentation, especially in elderly patients, right? So just by way of reminder as to what delirium actually is, it is a disturbance in attention, reduced ability to focus and sustain attention and awareness. And this involves reduced orientation to the environment, what's happening around you. And another important thing is that it happens over a short period of time. So this is something that's happening within a few hours to a few days. So this is not a gradual sort of loss of attention and disturbance in orientation. This is something happening acutely. Okay. Usually, you make sure it's not due to anything else that's happening. However, you can usually pinpoint it as to some physiological cause. So whether it is hypoxemia or it is, somebody who is septic, that kind of a thing. So it's an acute onset of a disturbed attention and orientation. And it usually occurs in the acute stages of COVID-19. In older patients, it is a common presenting complaint. So if you see someone presenting with delirium, an older person, then you have to rule out COVID. Okay? It occurs in up to 30% of patients who are hospitalized with COVID, and the percentage is even higher in ICU patients, as to be expected. What's interesting is that, in terms of general studies in ICU patients, they have been shown to have impaired cognition up to a year after recovery, which looks like mild Alzheimer's. So it means that even after the patient recovers and they go home, for up to a year later, they can still have cognitive impairment that looks like Alzheimer's disease. So that is something to be aware of and to check for. There has even been description of milder impaired cognition, concentration on memory, which some people describe as brain fog or long COVID. That might happen for months in patients who have been discharged from hospital, and even with those with mild disease. So long COVID fog is something that is still being investigated. It is still being researched in terms of as to how it's actually occur. So in terms of the particular disorders that we see, there are mood and anxiety disorders, depression mainly, and anxiety. Patients are at risk during and after COVID-19. And it's the prevalence is fairly significant, about a month after. Maybe about a third of patients will report depression, between 22 and 42% report anxiety symptoms, and 20% report obsessive compulsive symptoms. Acute stress symptoms and insomnia are also common. So acute stress is what we would normally call post-traumatic stress, but it's not going on for as long a period of time as to be diagnosed as post-traumatic stress. Insomnia is very common. So there are some people who are more likely to develop mood and anxiety disorders. So women, people who have family members who have been infected, people who are left with more physical discomfort after the illness, so they continue to have some discomfort. People who have more severe infection, they have also found people who have more inflammatory markers, and of course, those with pre-existing psychiatric diagnoses are more likely to develop mood and anxiety symptoms and disorders. Post-traumatic stress disorder was actually one of the most significant psychiatric diagnoses in survivors of MERS and SARS. And the incidence was up to 40% 6 months after discharge from hospital. And it is anticipated that the same amount, roughly, is likely to be found in COVID-19. Studies are ongoing. The studies that I've seen have had varying rates up to 80%. I don't know how reliable some of them are, but they do agree that there are risk factors for post-traumatic stress disorder. So younger patients, presumably because maybe they don't have as much resilience, right? Younger patients, women again, patients who have had to have ICU care are more likely to have PTSD, patients with a past psychiatric history, and patients who have delirium as part of the presentation for COVID are also likely to have PTSD. Interesting to note that there are risk factors for COVID and risk factors for PTSD in common. So there are high rates of obesity, diabetes, metabolic syndrome, cardiovascular disease, and autoimmune disease that is observed in patients with PTSD. Right? So the risk factors in common. In terms of psychotic disorders, it is interesting that pandemics and epidemics have always been associated with an increased risk of psychosis. Not only in patients, but in some environments too, I saw where children were born in the pandemics actually had an increased risk of developing schizophrenia in later life, in adult life. So viral infections generally increase the prevalence of psychosis, prevalence of 4%, which is higher than the general population. The general population prevalence of psychosis about 1%, 1 to 2%. There have been reports of new onset psychosis in COVID-19 patients. So these are patients who presumably have gotten ill because they have been infected with COVID-19. There's not much in terms of a characteristic presentation of these patients. However, it is said that these patients tend to be more confused and have than other psychotic patients. Right? We know, however, that stress of the pandemic can also precipitate psychosis by itself. And sometimes we have to distinguish between is it stress-related or is it the illness itself. And they have proposed some ways of distinguishing it there. That patients who are infected with COVID-19 and then become psychotic tend to be less delusional. They tend to have an atypical age of onset, and a fairly rapid recovery. As I said before, some drugs can precipitate psychosis, especially high-dose steroids. So that is something that we need to be aware of. In terms of management, just some general principles. You should consider COVID-19 infection or COVID-related stress in patients who present for the very first time with psychiatric symptoms, or in patients who you know have a psychiatric disorder with worsening symptoms. You should suspect COVID-19 infection if they have been stable all along. We should recognize that patients who have existing disorders are more likely to contract COVID-19, to have more psychiatric complications. As well, they tend to have worse outcome. Somebody's microphone. Over time, when you see the patient, you should monitor for cognitive effects, because we know that this can happen for up to a year later. So you might have to use tools. You might have to do a mini mental status examination on your patient as you follow them up in clinic or in your practice. You might have to use the clock drawing, tool, whatever it is, to keep an eye on their cognitive impairment to see if it is improving or worsening, if there's something else you need to do about it. And as always, we consider the effects of medications. It usually requires a multidisciplinary approach. So of course, not only the psychiatrist, but the internist and whoever else needs to get involved. Psychological first aid is something that we should do something about in terms of helping patients to manage, being able to prescribe exercise, relaxation techniques, increasing resilience in patients, and using appropriate investigations and medication as needed. For depression, of course, we will use the antidepressants, for example, the SSRIs. We tend to avoid paroxetine or Paxil because they increase risk of drug interactions. So just a very brief, because I know my time is probably off, to mention healthcare workers and COVID-19. Of course, we know that we are probably the most psychologically affected occupational group. And studies have shown that we have been having more problems coping than any other occupational group in terms of developing things like insomnia, post-traumatic stress, fears and phobias, anger, irritability, depression, and anxiety. So this is what has been happening. And we know why, because there's a lot of stress. If you have your own fears for yourself, you have to think about taking care of your family. You don't know what to expect in terms of what the pandemic is going to do. The positivity rate is one thing today, and in 2 weeks' time, it's something else. So we all need to be working on our own resilience. How are we able to withstand and rebound from adversity, right? Our own individual resilience, things that we need to look at. Are we connected with other people? Are we withdrawn when we get in? When we get home, we just want to shut out everybody. Communicating with other people, making sure that we get enough rest, getting help if you need it, find someone that you can talk to. So there are different things that we can do, and I'm going to encourage everybody to try and find something. Is it meditation? Is it going to be praying more? Is it going to be finding a hobby, do something completely different that you never did before in terms of coping? We all need to find a way to cope. And this is an ABC 1, 2, 3, which I found is kind of useful in terms of mindfulness is something that we can also practice. And that's basically just bringing yourself back to where you are at the moment. Don't let your mind get away with you. Do you need to get a stress ball? Do you need to get a pet? Do you need to do some gardening? I've killed up the plants over the COVID time. What is it that you need to do to look after yourself? Make time to do that. And for others, this is my last slide, just to be able to remember the whole patient, not just the illness, not just the COVID, but the whole patient, to be able to listen to the patient, to be able to provide information, to be able to reassure the patient, and to link the patient to get help, to educate the patient about normal responses, and let them know that it's okay if you feel anxious and if you're worrying, because everybody in the situation is feeling anxious and worried, right? Just to reassure them. So I would recommend, as again that you all make yourself familiar with psychological first aid as something that you can do to help the patients, and also to help yourselves, right? And to let you know, of course, the team is always here to assist.
Thank you, Dr. Gooden. Excellent presentation. I can relate to that in more than one ways, and many of us as healthcare workers, I know, can relate to what was just presented. We aborted the question and answers, but we will now take, I think we have one more for Dr. Batchelor, because I don't think that Dr. Spence is on. I'm not seeing her on, but we will take one from Dr. Batchelor. Two were in there in the chat for Dr. Batchelor. And we apologize for, we are hoping that Dr. Spence, if she gets back on, we'll continue with that for her. And for Dr. Gooden as well, we'll take a few. Dr. Clemens? Oh, I'm sorry. Oh, okay. So the question is the low incidence of COVID in the first trimester due to underdiagnosis, since these patients may not be obviously pregnant? And if so, would you recommend routine pregnancy tests in female COVID patients of childbearing age? And the other question is, what are some of the guidelines that exist to manage these maternal patients? I may have missed this. All right. What are some of the guidelines that exist to manage these maternal patients? Dr. Batchelor?
Okay, I'm sorry I lost you. I seem to have been speaking to myself for a very long time. So I had originally said that most of these most times when the diagnosis is made, it would have been, in terms of pregnancy, it would have been fairly, maybe about a month or so. As far as routine pregnancy tests for patients in reproductive age. So what I am going to start with is encourage all women reproductive age to be vaccinated. As far as the incidence in COVID-19 in the first trimester, it is possible that it's underdiagnosed because we're not aware of the pregnancy at that time. And like most of the patients who suffer illnesses are patients in the second and third trimester, in those patients who do not have an underlying condition or who are not at increased risk. As far as the guidelines that exist to manage the maternal patients, so there are well-recognized international guidelines, particularly by the American College of Obstetricians and Gynecologists. There is an algorithm that is available in terms of triaging the patient to determine whether they need hospitalization and what their follow-up will be. In terms of our local guidelines, the major guideline will be any patient who is of significantly higher risk, who is identified as being pregnant, must be at a high-risk institution. Any patient who is diagnosed positive in pregnancy must be properly evaluated, and where they are asymptomatic, as I mentioned, then they would have stayed home. and where there are symptoms and then they are hospitalized. The course for these patients is fairly dynamic and unpredictable, but there has to be a great vigilance for these obstetric patients.
Thank you. Thank you, Dr. Batchelor. Next question. Oh, these were the two. Is there any question from the participants? You can ask your questions, open the mic. You can also pose questions for Dr. Gooden as well. There's a question. Is it safe to administer antipsychotic medication to patients who may have developed behavioral changes?
No, try the festival.
Behavioral changes due to COVID or high dose steroid without psychiatric evaluation.
Okay, thank you. All right, so without psychiatric evaluation, yes, I think that if you need to, you can use, you just have to treat symptomatically unless, until you get psychiatric evaluation. If you have somebody who is grossly psychotic, who is very disturbed, who is, actively hallucinating and so on, then of course you do have to treat that patient until you see the patient see the psychiatrist. So yeah, definitely, yes, if you have to consult and find out how much to give, yes, you can give.
Thank you. There's another question for Dr. Gooden.
Hi, Dr. Gooden. How often have you seen the development of acute psychosis in non-hospitalized COVID positive patients?
I suppose that the answer would be we've not seen them. So we've actually seen a couple of new onset psychotic patients and who have turned up to be COVID positive. A couple, not a great amount, right? But of course, in our clinic setting, if we're seeing new patients, they would not routinely have been tested before they come. So I guess we would say not as yet, because we've not been sending all our new patients for COVID testing. So that our numbers are not great at this time, not able to say so much. There's another question. Which antipsychotic would I recommend? I guess it would be whatever is available. So we would recommend, as with all psychotic disorders that are due to a medical condition, that is start low and go slow. So we would normally use haloperidol in small doses on how the patient responds. Right? So haloperidol, risperidone are the most commonly used ones and most commonly available ones. Should they be referred to a psychiatrist after discharge? Yes, they absolutely should be, because we don't know how many of these patients would actually go on to develop a longer term psychotic illness. So after they're stabilized and they've completed their quarantine, please, we've had patients come to clinic who haven't completed their quarantine. After they've completed their quarantine, we may just refer them to our psychiatrist.
Okay, thank you, Dr. Gooden. There's another question. What medication would you recommend for patients with and without psychiatric illness who presents or develops confusion in the setting of COVID-19 to the point where their management is impacted due to lack of compliance with treatment?
All right, so sorry, could you read that question again? Patients who have been previously diagnosed with a psychiatric problem?
What medication would you recommend for patients with and without psychiatric illness who presents with or develops confusion in the setting of COVID-19 to the point where their management is impacted due to lack of compliance with treatment?
Okay. Okay. All right. So you're talking about delirious patients then, is what I'm gathering, right? So for delirium, you have to be careful in terms of sedation, and you don't want to use anything that might like a diazepam or something that might suppress the respiration, right? So again, haloperidol is an old faithful that doesn't cause much sedation, but does cause people to does cause some amount of help people to be more calm, then less aggressive and so on. So small doses of haloperidol, but then again, it depends on the patient. So if you have an elderly patient, you may not be able to give them any medication. You might have to restrain them. You might have to use other means to try and get them to comply, right, until their medical condition improves. But generally, you would want to start with small doses of medication, small doses of haloperidol in somebody who has delirium. Might be appropriate, or it might be appropriate just to physically restrain the person and use some other methods to try and get them to be quiet.
Thank you so much again, Dr. Gooden. Very excellent presentation, and that was posted in the chat along with some of the questions as well. I just want to remind the participants that we went up to a whopping 263 participants. We're down to 239. I'm just reminding you to register using the form provided. Once you have done so, this will generate your certificate. So you need not put in the chat that you need to get your CME hours, because that, once you register, we send that to the email from
Hi, good afternoon, everybody. Give me a minute, please, while I bring up present me. Okay, able to hear me? Right. Hi, good afternoon, everybody. It's great to be here today presenting to everyone, both in person and in the virtual world. My name is Sasha Dixon. I am a medical representative from Medimpex Jamaica Limited, and I also have with me my coworker, Mrs. Cheyenne McGoo. All right, she's also one of our medical representatives. Now, today I would just like to cover a few of our products with you. All right, and in keeping with the gynecology aspect of it, we have our Cleon D. All right, now our Cleon D is a combination of metronidazole and miconazole. It is our vaginal treatment for urogenital trichomonas infection, bacterial vaginosis, and also prevention and local therapy of candidiasis. Administration is 1 vaginal tablet, which is slightly moistened and inserted high in the vagina at bedtime for 10 days. Now, if your patients tend to have an issue with the 10 days dosing, you can also reduce it to them for 5 days, where they do either an insert in the morning and in the night for 5 days, or they do a double insert at night for the 5 days. All right, that regime will be a little bit more comfortable for your patients with regards to the amount of days. All right, now, just expounding a little bit more on the coverage. Now we know that bacterial vaginosis is caused by bacteria, and you detect it, of course, by the thin gray, usually increasing volume, unpleasant odor, etc. And itching is sometimes present. With a yeast infection, it is similar. However, this time the discharge will be thick and curdy, as well as the patient can experience some vaginal itching, burning, can even be painful urination. And then the trichomoniasis now, cause is by a parasite. You'll find that the patient will have a yellowish, greenish, or gray foamy discharge. They may have a fishy smell, and the discomfort that they experience will be like itching, burning, a painful urination can also be present. So all of these conditions, we have the solution for you for your patients in our Cleon D. Next up, we have a line of our oral contraceptives. And the first one that I would like to give you a reminder about is our Novinate, right? Now, our Novinate is one of our monophasic oral contraceptives. It contains 10 micrograms of ethinyl estradiol, 150 micrograms of desogestrel, and then it is a 21 tablet presentation. Now, it's gentle on the patient, and you find that it also does assist with clearance of acne. All right. Next up, we have our Lindinet, which is also a monophasic product. 20 micrograms of ethinyl estradiol, 75 micrograms of Justidine, and it is also a 21 tablet presentation. Lindinet proves to be a little bit more gentler on the system for your patients, reducing side effects that they may experience with a few others, as it is low dose, just like the Novinate. While Lindinet, again, it is a low-dose third-generation oral contraceptive. You're providing your patient with maximum effectiveness at a minimum dose comfort, excellent cycle control for maximum confidence, very few short-term side effects, offering good compliance for your patients, because, you know, when they're taking a birth control pill, they still want to feel like themselves, right? They don't want to feel the bloating and all of those side effects. So with Lindinet, you're also providing that for your patients where they remain feeling like themselves. Next up, we have our Mistral. Now, Mistral is our low-dose 4th-generation combined oral contraceptive with anti-androgenic properties. This time it contains 0.03 milligrams of ethinyl estradiol and 2 milligrams of Dinogest, also a 21 milligram tablet. Now, the advantages that you're providing your patients when it comes to Mistral is that you're giving them reliable ovulation inhibition with high contraceptive efficacy, provides effective cycle control with reduced intensity and duration of the menstrual bleeding. It will improve dysmenorrhea. You're also providing your patients with the benefits for clear skin and hair, reducing the greasiness of the hair, sustained cycle stability. All right, so that's the coverage of all our OCPs. Now, on following with presentation earlier, we have our Lottie Girl. So you may find that Lodogrel could be useful in the COVID-19 discussion that was had earlier. So this is our 75 milligrams of clopidogrel. And the indication, of course, that we have it for is for atherothrombotic events, myocardial infarction, ischemic stroke, acute coronary syndrome. And the dosage is once daily with or without food. Very affordable product is between $75 to $100 per tablet for your patients. All right. Next up, on touching on the depression topic that was also covered earlier, we have our Stimulotan, right? It is a 50 milligram presentation of sertraline, and it is a selective serotonin reuptake inhibitor. Now, the advantages of using Stimulotan with your patient. Now, first of all, Stimulotan is going to lift you out of depression, right? So, Stimulotan is used to treat depression, OCD, and panic attacks, all which were covered in the COVID discussion earlier as, you know, things that can happen to patients after this whole pandemic or during. All right, now the dosage for Stimulotan is once daily. There's an 80% response rate, better tolerated, decreased panic attacks for your patients, and also it is effective in premature ejaculation. Now, what are the dosages? When it comes to depression and OCD with Stimulotan, the dosage is 50 milligrams once daily with food, right? And your patient will feel complete therapeutic effects after 2 to 4 weeks. When it comes to panic disorder, within the first week, it's a 25 milligram once daily dosage with food. And then for the second week, you may increase it to 50 milligrams once daily with food. Complete therapeutic effects is felt after 8 to 12 weeks. Now, the maximum advised dosage of Stimulotan is 200 milligrams per day. With regards to the off-label use, which is premature ejaculation, we have a 50 milligrams once daily for 6 weeks, and then when needed thereafter. As prophylaxis, 50 milligrams per night, 2 hours prior to sexual intercourse. Now we're gonna cover a few of our over-the-counter products. This is our Sorbifort Durance, right? This is our iron supplement. It contains 320 milligrams of ferrous sulfate elemental iron, 60 milligrams ascorbic acid. Now the price on the market is roughly $23 per tablet, and the dosage is 1 to 2 tablets daily. However, in severe anemia, your patient can take up to 3 tablets daily. What are the advantages of taking Sorbifort? Now, with Sorbifort, you're providing your patients a less chance of constipation due to the fact that it's a slow release technology, right, of the iron. You're also providing your patients with less GI irritation, which is very important, faster absorption of iron due to the vitamin C content, the size, because it's a very small tablet, so it's easy to take, odorless, and it is affordable. All right. We also have, when it comes to your children, we have vitamins available. And this is our Prime Health brand, and it is called the Prime Health Multivitamin for Children. Now, as you can see on the bottle, you're providing the kids with a full coverage vitamin A, C, D, folic acid, vitamin E, etc. All right, they are gummies and they taste wonderful. So you can look out for these on the shelf for your patients. Also on the market as an OTC product is our Prime Health Prenatal Vitamins. So in touching with the premature birth, etc., we want to keep the mothers healthy. We want to keep the babies healthy. So you can prescribe our Prime Health Prenatals for your patients. You're providing them with coverage of calcium, biotin, folate, copper, iodine, iron, etc. All right, all of what is needed and essential for your prenatal patients. Next up, we would like to cover our Covonia line of products. All right, and we have a wide range of products when it comes to Covonia. We have the chesty cough preparation, chesty sugar-free, bronchial balsam, dry and tickly, nighttime, cold and flu, catarrh relief, cough drops, and throat spray. So just to cover a few of them, now you'll see here where it says Covonia lozenges. We have repackaged and revamped it. They are now called Covonia cough drops. They are all extra strength and they come in 3 different flavors: the berry flavor, the original, and the strong, the sugar-free. All right. Now for the berry flavor, it has 2 layers, which provides a warming and a cool menthol on either side. Indication of our Covonia cough drops is for sore throat and loss of voice due to hoarseness. Next up, I would like to introduce to you, or remind you rather, of our Covonia throat spray. Now for me, the Covonia throat spray is magic. It works, it helps your patients, right? It contains 0.2% chlorhexidine as well as 0.05% lidocaine. The chlorhexidine is the antiseptic that prevents bacterial growth. The lidocaine is an anesthetic which numbs the pain. So when your patient is presenting with a painful sore throat due to a bacterial infection, Covonia throat spray is your answer. There's a special applicator, as you will see on the bottle, and it allows the spray to be applied deep into the throat directly to the affected area, which is a very big plus because you're ensuring that you're treating the actual area that is affected. And this is a coverage of our products. Thank you very much for having us here today.
All right, so no Terry.
And I'm sure you must find something of what she has, one of those medications she have mentioned. You must find use for those. Up next is our final presentation for the afternoon. And this one is a treat. I have on my program, cough medicine, use and abuse. But this presenter for this presentation is someone who works behind the scene. She actually has a name on the program, but I understand that she is going to step in. I'm not seeing Dr. Baker on, Dr. Terry Baker, who should have been doing this presentation. But of course, the mastermind behind these motivational seminars has stepped in, and I'm sure she will do justice. Our pediatric consultant, now SMO for Spanish Town Hospital, Dr. Jacqueline Wright James, will present cough medicines, use and abuse. Make her welcome, please.
Thank you so very much, Director of Nursing Services. I just want to do a disclaimer. I'm no authority on the subject. I'm a pediatrician by trade. But Dr. Baker, well, I'm hoping that she will come on at some point, but she really sends her apologies if she doesn't make it. I hope she'll be here to answer the questions because I might not be able to. But I think I've done some reading, and with the support of Dr. Baker, we're going to try and just go through briefly this presentation. Thank you for staying on, and we are just about on our last topic. So as I'm speaking, I'm looking for Dr. Baker, but she does have quite a busy schedule. As you know, she's SMO at National Chest, and she really has got caught up. But what is a cough? Expert to make a try of it. All right, so cough, otherwise known as tussis. And basically the purpose is to clear the throat and the breathing passage of foreign particles, microbes, irritants, fluids, and mucus. It is a mechanism to clear the airways of mucus and foreign bodies. And I mean, we all know what a cough sounds like, but it results from a rapid expulsion of air from the lungs. There's an inhalation, forced exhalation against the closed glottis, violent release of air from the lungs following opening of the glottis, and finally that distinctive sound that we all know. There are differences in how it sounds based on where it results from. And as you know, mucus secretions are normally removed by ciliary beating. When this defense mechanism is impaired, lots of secretions in the airways, then cough becomes an important means of removing these secretions. My slide's not working with me, not changing. All right. All right, so these are simple things, but how does a cough, how is a cough produced? It's a reflex phenomenon. And as we know, all receptors it's somewhere that detect an issue. So there are sensitive receptors located in the larynx and in the upper airways. They are activated. You have no receptors beyond the bronchioles. And of note, the lung parenchyma has no cough receptors present in it. And hence, just to add there that you can actually have a pneumonia, which is infection in the lung parenchyma, and not have a cough. These receptors generate information which reaches the central nervous system. And unlike swallowing, where you actually have a specific center that is well defined in the central nervous system, this is an ill-defined area, but it is thought to be somewhere in the medulla that these that the information generated by these receptors reaches to. The receptors that are present in the airway are of two types. You have the rapidly adapting receptors, which are linked to myelinated fibers of the vagus nerve, cranial nerve number 10. And you have other receptors, which are non-myelinated, C fibers. And when these are activated, these receptors release neuropeptides, which in turn actually activate the rapidly adapting receptors. So they work hand in hand. So there are two types of receptors. No sign of Dr. Baker. All right, so cough receptors, basically this is just showing you where they are. You have in the nasal cavity, you have in the larynx, you have in the pharynx, you have in lung, but not in the parenchyma. It stops at the bronchioles, but not in the parenchyma itself, but it stops at the bronchioles. You have cough receptors in the heart, cough receptors in the pericardium, cough receptors in the esophagus. And I want you to note too that you actually have cough receptors in the ears. And hence too, you can have ear pathology without upper respiratory tract pathology that can actually trigger a cough. So the vagus nerve is the main nerve in the afferent pathway that results eventually in a cough. Dr. Baker? So you have, I mean, people will describe their coughs in various ways, barking cough. So you know that, that the dog barking, and the dry cough, which I mean, clearly, you know, it's not wet. It don't sound rattly. You have the mucus cough, that is a rattly one. Well, mucus coming up actually, but and then you also have the wet cough. So mucus means that you actually see something coming up. Wet, especially in the children, and I can speak on that part, the cough may sound wet, but you may not, because they can't expectorate it. You may not actually see the mucus. And of course, we all know about whooping cough. If we had Professor Christie online, she's very good at really making you know what the whooping cough sounds like. I can't forget her presentation on that. So the causes of cough, really when you're looking at cough, and with most pathologies, you divide it into acute, subacute, and a chronic cough. And for the purpose of this presentation, we probably will stick more to the acute cough and the subacute cough. So by acute, it means it's a short duration. And most of these problems can actually lead to a cough that can linger on for even up to 10 to 14 days when you have the common cold. So the most common causes will be the common cold and upper respiratory tract infection. But there are other things that can give you acute cough: pulmonary embolism, congestive cardiac failure, pneumonia. But remember, you can have pneumonia without a cough, and exacerbation of pre-existing conditions. So you're asthmatics. Subacute coughs, which are 3 to 8 weeks. So your cough is lingering for more than 3 weeks. The postnasal drip, and those patients who have hyperresponsive airways, again, seen in your asthmatic patients, can linger on for quite a while with their coughing afterwards. So how can we have a presentation on cough and not specifically single out COVID-19? So of course, COVID-19, mild disease is really the common cold. When you start to have moderate disease and you have a pneumonia, when you start to have severe disease, you have a pneumonia plus hypoxia. And when you have critical disease, your lungs have failed and many other organs have failed along with it too, unfortunately. So COVID-19 and cough. I hope Dr. Baker is listening in and about to save me. But the dry cough is a common early symptom of COVID-19. It's almost like I find with the other viruses, you tend to have that prodrome of the runny nose, and the cough will come on about the 4th or 5th day. COVID-19, almost from the get-go, if you are symptomatic, that dry cough presents itself. And in various studies, as you know, we've been at this pandemic for well over a year, and many studies have been done with regards to presentation. So 60 to 70% of patients with COVID-19, that's their initial symptom. Usually one day after becoming ill, and it can last for up to almost 3 weeks. And it persists for even longer than 4 weeks, that's 1 month, in around 5% of people. It is a feature of long COVID, the long haulers, and alongside fatigue, dizziness, and joint pain. But usually, you know, one of the questions on returning to work to be released from quarantine is, do you still have a cough? Usually after 3 weeks, and that if you have a cough, it's probably not because of infectivity from COVID. And you know, you will have to be reassessed, but that won't necessarily keep you away from returning to work. There are many online surveys, and it published in the Lancet Respiratory Medicine. And again, just confirming that this dry cough can be a persistent symptom. And they actually say that 30% of them, this is long COVID, will go up to 2 to 3 months after becoming ill with COVID-19. So COVID-19, one of the features is definitely that cough, which can persist. So our main area here now is treatment, and I know and there are many products that are available, and we're going to look to see how we should use them, should we use them, and ensure that we don't abuse them. So we have the antihistamines, the famous diphenhydramine, and it has its mnemonics, DPH. It may act to reduce coughing by the suppression of mucus production in the upper respiratory tract. We have our antitussives, we have our mucolytics, and they've done a study in Australia that shows that it was a call-in study. 40% of the parents whose children had a cough, they picked up some sort of cough medicine at the pharmacy. So these are 3 types. And over-the-counter symptomatic medications for cough and cold raise particular concerns. They have potential undesirable side effects. They can cause hypertension. You can become addicted to it. Drowsiness. It can reduce seizure threshold for patients who have seizures. And sometimes too, it can delay the diagnosis of what you're trying to really treat, the definitive cause of the cough. And this is where my strong point is now, the children under 6. The studies have shown that there is a limited efficacy of certain cough and cold medicine constituents, and it actually has associated adverse reactions. Over-the-counter drug abuse was most often reported with codeine-based medicine and cough products, particularly the ones that had dextromorphin, and this was shown in a PubMed search that they between 1960 to 2004. So let us look quickly at suppressant specific antitussives. It incorporates the use of pharmacological agents with mucolytic. So various ways it works. It's going to inhibit effects on the cough reflex itself, or it can actually exert mucolytic effects. Dextromorphin, as I mentioned, this is the most common one. And you see a lot of the cough medicines will have DM at the end of it. And we tend to use, if we're using these for dry, irritating coughs. Another ingredient in a lot of these antitussive medications is codeine. And the exact neural elements of how these drugs act is really not currently known. And it is thought to inhibit a functionally identified component of the central system. So somewhere in that medulla for cough, and it is known as a gating mechanism. And the efficacy of codeine and DM in humans has recently been questioned. And it is thought really to be only indicated if cough is causing discomfort, and if it is suppressing the body's protective mechanism for airway clearance and not going to delay healing, then you may consider it if it is a dry, irritating cough, but definitely not for the children under 6 years old. We have the expectorants, and we all know those, we call them protussives. So you have cough with phlegm can be a good thing because you're clearing stuff. So it's not that you want to get rid of it, all in one go. It has its purpose. It's serving its purpose. Some people even say drink water. And you always know sometimes you cough, people give you water to drink. Does that really work? So one of the main ingredients that is included in the expectorants would be your guaifenesin. The efficacy again of protussive therapy has not been well documented, and some people actually say it's better to use some hypertonic saline aerosol. This medication can cause nausea and can cause significant vomiting. This really just showing you, this is part of the PubMed search that they did between, I think, 1960 to 2004. And they looked at the effects of mucociliary drugs like ipratropium bromide and bromhexine. I don't call any names, but bromhexine is one common one that is present in one of our cough medicines. We have bromhexine. But ipratropium bromide. So this 1, 2, 3, the fourth column is the age of the patients who they found the studies on. And there's really was no use for upper respiratory tract infections. And they even looked at the use, certainly for chronic bronchitis. Ipratropium bromide was the only thing that probably played a role in the management of the cough in chronic, but there was no role in upper respiratory tract infection. Bromhexine versus placebo really had no effect on cough clearance, whether acute, chronic, asthma, etc. Please do not give your asthmatics cough medicines. Guaifenesin, which as we said is one of those expectorants. Again, they looked at it in the 18 to 30. This was again the PubMed search, and it was found over all the years that it has no significant effect on cough frequency. The cough suppressants again, so basically you're picking up the gist that there really is no significant difference in using most of these medications versus placebo, and hence the risk benefit you really have to assess. They do come with quite significant side effects. May be recommended in the upper respiratory tract infection if it's a dry cough and if it is very irritating, disturbing sleep, those kind of symptoms, but it's not going to clear the cough any faster. It's not going to make you get better any faster. It's not going to prevent it from going down into your lungs and causing pneumonia. And it's not going to stop you from becoming an asthmatic. Other medications, Vicks, menthol, and we saw our sponsors. I mean, they have a lot of the cough drops that contain the Vicks and the menthol. And trust me, I find that it really does work in terms of the menthol. Don't ask me the physiology behind it, but these are safe and they actually do have some impact on the cough. But none of these medications are going to make the cough go away any faster. If you're going to cough for 100 days, no matter how much cough medicine you prescribe, the patient is going to cough for 100 days. And some of the medications, be careful of the combinations, especially if it has things like pseudoephedrine in there, which can have hypertensive side effects. So you must know what the medications contain, know what comorbid problems your patient has, and really analyze and see, what's the benefit to gain from giving this cough medicine? I haven't put honey, but I thought honey was a Jamaican thing until I looked on the American Academy of Pediatrics, and there was honey on the website saying as a part of the treatment for a cough. I said maybe it's a soothing effect that it has. Remember, no raw honey in children under a year, but honey is something, and we see a lot of cough medicines with honey and lemon. Maybe they smell like the menthol. Actually does help to just make you breathe a little better, clear the air passages a little better. But at the end of the day, it doesn't really make you get better any faster or prevent worse symptoms. And zinc is another controversial one, and the studies show that zinc has no impact, has no effect on the cough. So I'm wrapping up here and then hand over to the expert. In summary, as caregivers, as healthcare workers, and as, who knows, as patients, we should be aware of the common cough and cold interactions and communicate the likely clinical symptoms to our patients when prescribing medication to prevent potential harm. These drugs are less effective on cough induced by upper airway disorders, and therefore that is your upper respiratory illnesses such as COVID. So less effective on those things. Probably a little bit more effective on the problems with the lower airways like bronchitis. And as if you remember, the real main thing that really had some impact on that was your ipratropium bromide. They have done a lot of randomized controlled trials. OTC cough medicines do not appear more effective than placebo, especially in the acute cough. Patients with acute cough due to the common cold over-the-counter combination, be wary of those. But the good old antihistamine, based decongestants actually are pretty safe, and but are they necessary? We use those mainly more for coughs related to allergies. Patients with chronic bronchitis, agents that have been shown, and this is just to repeat, really the cough suppressors, are not effective, but ipratropium bromide has been shown to have some effect, which is the last point. And there ends. So I think in summary, really, certainly in the pandemic, in the climate of COVID-19, cough is one of the predominant symptoms seen very frequently, but we must look at the kind of cough. Remember the age of the patient. Remember if they have underlying problems such as asthma and chronic bronchitis, they're definitely maybe not recommended. And remember the side effects and the interactions with other medications before you prescribe. And if nothing else, especially for the children under 6, really the recommendation is that they don't work and probably should avoid them, especially in that age. I thank you. Please point your questions to Dr. Baker, and I hope that Dr. Baker can add something to my presentation. I thank you for enjoying me. Thank you for listening. Dr. Baker, over to you. Thank you so much for joining us.
So ladies and gentlemen, there you have it. You listened, and I'm sure you can make your own judgment. You heard the presentation, you got quite a bit of facts. I heard the call for backup. I understand that Dr. Baker is now on, but our SMO is a true Virgo, and she celebrated her birthday just a little over 2 weeks ago, although it doesn't show. Both of us celebrated birthday just a little bit over 2 weeks ago. It's not showing on her. I don't know what has been happening. Looks like her cough syrup works a lot, but I don't know if there are any question posed in the chat. Dr. Baker will just pick up there. Dr. Baker, I don't know if there's anything to add. I hardly think so, but you completed. Is she on? Okay, are there any questions, anything that you think Dr. Wright James left out? I know you got some solid facts. There are no questions. Oh, ladies and gentlemen, while you're posing your question, please remember that to do the survey that's posted in the chat. That helps us to plan our next session. We want it to be very interesting. We want it to be something that you want to hear about. So we ask that you participate, because most of you do not want to let your voice be heard. So we ask that you put your fingers to work and complete the survey. And we also remind you, if you have not yet done so, to register via the form that was placed in the chat so that you will get your CMERs. No questions? Crystal clear, which brings us to the end of our, us to the end of the seminar for today. I now ask Dr. Andre Vassiano to give the vote of thanks. Dr. Vassiano?
Hi, Matron. Is everyone hearing me? Is everyone hearing me?
Yes, sir, loud and clear.
Yes.
Okay. Good afternoon, everyone. Thank you very much for joining us today, to all the participants and the presenters. Thank you very much, Dr. Wright James, for asking me to give this vote of thanks and my few comments. As everyone can appreciate, I imagine, it really does take a lot to get an activity like this off the ground. I think we all agree that today's activity was a success. At one point, we had over 260 participants. That's wonderful. I suppose there are various persons that are involved in making something like this work, as well as it has. I want to single out Dr. Wright James and her team for putting all of this together. This really was wonderful. Thank you very much. So thank you as well to our sponsors, Medimpex. You have many useful products, and I encourage all the participants here to, well, to endorse your products. Very useful indeed. More than everyone else, though, we really do need to big up and thank in a very special way our presenters, Dr. Nicholson Spence, Dr. Batchelor, Dr. Gooden, and Dr. Baker. Thank you very much for the presentation submitted. Dr. Nicholson Spence, it was a very timely reminder on the physiology of clotting, etc. And it's, as you said, a very topical subject. I think all of us have benefited from what you presented today, and it will impact our practice going forward. Dr. Batchelor, your presentation, very important as well. The continuance of life, COVID-19 and its effect on that process, on the in utero passenger and the mother, the pregnant mother. We really enjoyed it. I'm sure I can speak for everyone else. Extremely informative. Thank you so much. Dr. Gooden, at times we, as physicians, certainly perhaps as surgeons, we underappreciate the importance of the psychiatric, the mental component to illness. And you brought that to bear as well today. We recognize that COVID-19 has multiple impacts on the organism, so to speak, and it's not all just physical. Thank you for shedding some light on the psychiatric impact of it. Dr. Baker, thank you so much for doing the presentation. I can assure you, I don't know if you're on board with us now, but I can assure you that Dr. Wright James did you justice. She presented excellently as you put forward. Your topic was wonderful, very important as well. It's so easy to overtreat and to undertreat, because the truth is many of these medications are thought to be quite benign, and as you've shown, can have very significant. Let me just thank the participants for joining in, all 260 odd of you that took the time out today to participate. I hope that this has been as useful to you as it has been to me. And we look forward to the next iteration. Thank you very much again, Dr. Wright James and team. Take care, everyone.
Thank you so much, Dr. Vasiana. I also want to add my bit of thanks to prayers that were offered by Mrs. Yulene Hyatt Beckford, and to the persons who worked behind the scene, Dr. Beckford, Dr. Clemens, Dr. Smith, and you already did our sponsors, and we have the persons who decorated the room, Mr. Powell and team. I just want to say a big thank you, because the ambience is one which makes you would have wanted to come to be here today, had it not been for COVID. It was my pleasure, and I also want to thank Dr. Vasiana for thanking everyone. It was my pleasure to have chaired the program this afternoon. We looked at anticoagulation and COVID-19 among the causes of premature births. We looked at the psychiatric perspective, COVID-19 pandemic and the psychiatric perspective, which we all can relate to. And we looked at cough medicines during this pandemic. It was my pleasure to have chaired this afternoon. Thank you all for staying to the end, and we look forward in another 2 months for our next session. Thank you all. Have a good afternoon.
Excellent presentation. Great job, Matron.